Thanks a lot for the introduction, and good morning again, or maybe good afternoon. So indeed, a few slides about the use of TE for the hemodynamic assessment in our patients in intensive care unit. Just to remind you some key points regarding the training progress of all of us. And as you know, we defined many years ago something which is basic, mostly in relation with the use of transthoracic echo. And you have in between the expert level and the basic level something which is the advanced critical care echo, which really needs at that stage to be able to use TEE, because this is probably the best approach to assess fluid responsiveness, especially, and to have an adequate evaluation of the cardiac function in mechanically ventilated patients. Just to tell you also that a few years ago, it was defined by Michael Pinsky and Didier Payen, something called functional hemodynamic monitoring, which is really something that you may apply using the echo and especially the TE. And I want just to give you some points regarding the main issues of hemodynamic management, and to compare the conventional hemodynamic monitoring approach to a more functional one based on the echo use. So for instance, for fluids, if you use the conventional approach, you will determine the preload, especially based on the CVP and the PAOP when you use the pulmonary artery catheter. Using the functional hemodynamic monitoring, this is more based on the response to the treatment, and so you will assess for the fluid responsiveness status. About the inotropic drug, by the conventional approach, you need to have the association of cardiac output and wedge pressure to determine the LV systolic function. While using the functional approach, maybe we have some data suggesting that once again you may look at the effect of the butamine, especially in patients with septic shock in case of LV systolic dysfunction, what was called the butamine stress test. About the cardiac output, the conventional approach is more that it gives you a value, a number, while with the functional one, using the echo, your goal, your objective is more to determine why this cardiac output is inadequate. You know it is inadequate because the patient is in shock with skin mottling, with high lactate level, but you want to determine why the cardiac output is inadequate. And finally, for the pulmonary circulation evaluation, with the conventional approach, you have some parameters of RV afterload that we discussed this morning, as pulmonary vascular resistance or pulmonary artery pressure. While using the functional approach, this is more based on the heart-lung interaction, and especially as we discussed also this interaction between the ventilator and the right ventricle. So when you want to perform how to use, TEE, first you have three different situations, I would say, based on my experience and also on the literature. The first one is that you want to do the TEE because there is a clinical issue with your patients. The patient is hypotensive, the lactate is elevated, there is oliguria, or maybe skin mottling, and so on. And so you want to understand what is the problem, what is the issue. The second situation is that you perform systematic hemodynamic evaluation as something completely integrated in your clinical evaluation, a daily morning evaluation, and this is exactly what we do in the most severe patients, as patients with septic shock or IRDS, at least at day 1, day 2, or day 3 following their admission in the ICU. And the third situation could be to evaluate the hemodynamic changes related to the treatment that you modify or you apply, and especially the impact of PEEP, the impact of prone position, the impact of infusing norepinephrine or the butamine. And so you have to choose the right hemodynamic evaluation for that, which is either transthoracic echo, but as I told you, at least on my experience, mostly TEE in mechanically ventilated patients. And I think this is key that after enough experience, it means that after studies and studies and studies, you will be able to mostly apply a qualitative evaluation of the hemodynamic and maybe to avoid any useless numbers of the parameters, and just to tell the LV is moderately, severely impaired, or maybe normal or hyperkinetic, but maybe you have not to give exactly the ejection fraction to adapt the treatment in the critically ill patients. After that, you have by definition to apply the right decision and the right treatment. And especially, really, I want to insist on that to avoid repeating the mistake that we made with the PAC. It means that this is because you have a more qualitative evaluation that you are able to apply the right treatment, while in the past, with the pulmonary artery catheter with too many numbers, most of them, or not most of them, but some of them wrongs, it was a challenge to apply the right treatment. And finally, the re-evaluation is really also key, just to be sure that you did not do any mistake following your first evaluation. And so, for instance, if you use the TE, I will say that you have the main views and the main information for a complete hemodynamic evaluation, which is first here the mid-esophagus view, which give you mostly the size of the RV, and you visualize here that the RV shape was triangular, and so the RV was non-dilated. From this view, you may put the pulsed wave Doppler at the mitral valve to record the mitral inflow, and especially the E wave, which is the early diastolic wave, and the A wave during atrial contraction. And so, as you know, it may give you some information about the LV filling pressure or the LV diastolic function. If you move down the probe into the stomach, you are now able to record the transgastric view with here this posterior wall of the LV, the anterior wall, the interventricular septum, and the lateral wall. This is probably from these views that first you are able to evaluate the LV systolic function, and second, to have the detection, if any, of the paradoxical septal motion. From this view, if you rotate the ultrasound beam just to visualize the LV outflow track, you may use once again the pulsed wave Doppler into the LV outflow track to record the LV ejection flow, and maybe if you want to measure the VTI of this flow, which is related to the LV stroke volume. From this view, what is this view? We remove the T probe at the upper esophagus view, so the great vessels, and we want to visualize here the supravena cava in its long axis view. For that, we need to rotate the ultrasound beam at 90 degrees, and so by combining the 2D with the time motion study, you visualize here the SVC along the respiratory cycle. And when you visualize this kind of collapse during third-eye ventilation, you get good information about the need for more fluids. And finally, of course, from the mid-esophagus view, if you use the color Doppler, you are completely able to detect a huge or massive mitral regurgitation, which may give you information, especially, for instance, in patients with pulmonary edema. And we reported in this study that For these parameters, I mean for the SVC respiratory variation here, and for the LV ejection fraction or fractional array contraction, so parameters of LV systolic function using the TE, we were completely able to evaluate these parameters by a qualitative evaluation. Just to show you that here we asked to our doctors just during the examination to tell us if there were no SVC variation, moderate SVC variation, respiratory variation, or major respiratory variation. And post-analysis, we measured the SVC collapsibility index, and you can see that the doctors were very well trained to qualitatively assess this respiratory collapsibility index. We did exactly the same for the parameters of LV systolic function, with some more overlap, especially between moderate or severe LV systolic dysfunction. But you can see that it was not so bad. And so with some training using the TE, it was completely, they were completely capable to qualitatively evaluate these parameters. So what about the fluid monitoring using the TE? Very briefly, because I do not have enough time, but the SVC respiratory variation, as I told you, is really key, and especially when you detect this kind of collapse. This means that the patient, if the patient is in shock, of course, requires more fluids. And this is something that you may either calculate as the collapsibility index, or as I told you, qualitatively evaluate. If you want to calculate, you measure the maximal diameter at end expiration, the minimal diameter at the plateau, and so using this formula, you have the collapsibility index. And in this pilot study in septic shock patients, we demonstrated that it was not bad to predict the response to fluids. Of course, from the pulsed wave Doppler into the LV outflow tract, as I told you, indeed, you may first evaluate the VTI, but you may have also some information regarding the respiratory variation of this flow, which was demonstrated to be associated with a response to fluids. But be aware just that, as I told you this morning, this is more a parameter that the LV is preload dependent of fluid responsiveness, but it does not tell you that the cardiac, the heart in its globality, is really fluid responsiveness. And as I show you this morning, this LV could be preload dependent because the RV failed, but the patient is finally not responders to fluids. And in this big study that we did and we published a couple of years ago, we included at the end 540 patients, all mechanically ventilated. Some of them, I think 20 to 22% were ventilated for acute respiratory distress syndrome. And most of these patients had a TE to evaluate, for instance, the ability of the respiratory variation of the velocity of the LV ejection flow here, or the SVC, to predict the response to fluids. And we also combine that with the pulse pressure variation and the respiratory variation of the inferior vena cava by the transthoracic approach. And just to show you that the SVC was the less worst or the best parameter if you look at the area under the RUG curve to predict the response to fluids compared to the other parameters. And just have a look on the respiratory variation of the IVC, which was really not good. So it's probably not the best approach to manage fluids in the patients. This is the same information with the RUG curve. The respiratory variation of the SVC is in blue. What is interesting especially is not to use probably a magic cutoff value, but to have more a gray zone approach. I just want to show you here. You have, if you want to be sure to have a high sensitivity for the respiratory variation, so you do not want to have any false negative. Indeed, the cutoff value is very low, probably not very safe as in the range of the variability. But if you want to have a high specificity, for instance, because you have to manage a patient with RDS and you don't want to infuse useless fluids, you want to be sure that if you infuse fluids, it will be useful. And here you have the cutoff value for specificity of 90%. Once I told that, this is the, let's say, our approach. But if you look at the real life, and especially worldwide, this study, the Fenice study, is really interesting because it was worldwide, 46 countries, more than 2,000 patients analyzed about the way they use the need for they manage, sorry, the need for fluids. And it's a little bit disappointed because you can see that in 42% of cases the intensivists did not use any variables. When they use one, they use the CVP in 25% of cases, while we know that the CVP in this issue is not very valuable. They use pulse pressure variation in only 4% of patients, which is not a big problem, but and they use only the echo variables in 2% of cases. So it means that even if the echo is very popular, there is a lot of work to do again to convince the intensive care doctors that echo variables, and especially the respiratory variation of the SVC using the TE, is really key to better manage the need for fluids. And just to conclude with this study, that's interesting because you have here, according to the response to the first fluid challenge, what the doctors did in terms of second step or not of fluid administration. And you can see that whatever was the response initially, a positive response, an uncertain response, or a negative response, in all cases, which is around 40 to 50% of cases, the intensive care doctors did a second step of fluid challenge. So this is a big problem in the way we manage the need for fluids. Just a few slides about the use of TE in septic shock. Just to show you that when you perform TE, sometimes you have this kind of picture in the patient in shock. You visualize that the LV is severely dilated and with a very poor LV systolic function, and even you have some clot inside the LV. If you combine this picture with the mitral inflow, you recognize that the mitral inflow was restrictive with a much higher E velocity compared to the A velocity. So you have many information from this evaluation. First, the LV is dilated, so there is a chronic injury, a chronic process. Second, the LV filling pressure is elevated, so you have a typical cardiogenic pattern. This patient had a cardiogenic shock. And finally, you have indeed the clot inside, which is something probably more related to a chronic process. At the opposite, if you look at the patient with septic shock developing septic cardiomyopathy, the LV is non-dilated. You have also a very poor LV systolic function, but once again, the LV is non-dilated without any clot. And if you look at the mitral inflow, there is no more restrictive pattern, so no argument to detect any increase in LV filling pressure. So this is more a typical pattern of septic cardiomyopathy. So LV systolic dysfunction related to the cytokine release and the infection process. And that's important because this is something that you may to understand using the TE. that the LV systolic function, when you record, this is true also for transthoracic echo, is indeed related to the intrinsic contraction of the LV, which is represented here on the x-axis with the maximal elastance of the LV, but also to the afterload. And that's really key because in septic shock, as you know, many patients were vasoplegic with low blood pressure, at least at the admission. Look at, for instance, if you perform the TEE when for a very poor contraction of the LV at the admission with a low blood pressure, you will find a normal LV ejection fraction. But you can see that if you restore the blood pressure with the norepinephrine, and for the same intrinsic contraction, now you will unmask this injury of the LV with a depressed LV ejection fraction. And this probably explains the different incidents that you observe when you evaluate the LV systolic function in patients with septic shock. You have some studies in which the incidence is 18% when the LV systolic function was evaluated at 6 hours following the admission. After 12 hours, this is 26%. After 1 day, this is 35%. And finally, during the first 3 days, this is 60%. And this is probably not really related to any change in the LV contraction, but probably this is related to change in the LV afterload, because along the time, doctors were able to correct the vasoplegic status and so to normalize the LV afterload. And look at, for instance, this.
I trust your time is over. I'm
sorry
for
the sound. You have here at baseline this very poor LV systolic function. Also, this is just to show you, sorry, the effect of the butane, but I cannot see the title of my slide because of the bar of the Zoom program. And after infusing, you can see some restoration of the LV systolic function. Finally, I want just to tell you that if you use the echo and especially the TE, you may have 4 situations regarding the LV. The first one, as I told you, which is this one, you have an isolated, LV systolic dysfunction. The second one, the LV is hyperkinetic, but the problem is the RV failure with RV dilatation and paradoxical septal motion. The third one, and now this is transthoracic approach, both ventricles were impaired, the RV was dilated, and the LV systolic function was very poor. And finally, the last situation is that an hyperkinetic LV, probably reflecting a profound vasoplegic status. Look at, for instance, this patient. Once again, I show you, this is before the butamine infusion. So we were able, using the TE, to monitor the effect of infusing the butamine here compared to baseline, just to control that indeed we induced a much better LV systolic function. I just want to show you something that when you infuse the butamine in this case, look at the heart rate. The heart rate is not expected to increase too much or even to slightly decrease it. It really means that you improve the LV systolic function and so the stroke volume. If you decide to infuse the butamine based on your echo, and if you look at that the patient is now arrhythmic or very tachycardic, it probably just means that you did some mistake and you did not apply the right treatment for the patient. Look at once again this example, or this one. I just want to show you this. Sorry, I don't know why I have this kind of issue. So look at here this patient about the norepinephrine. So this is the admission. The LV was hyperkinetic, but the patient was vasoplegic with the low blood pressure. We decided to infuse norepinephrine and look at few hours later, after restoring the blood pressure, look at how is different the LV systolic function compared to the baseline. Few words very quickly about the Harvey function. Just to show you, you have still three situations. First, the Harvey is non-dilated. Second, you have a moderately Harvey dilatation with a paradoxical septal motion or without. And finally, you can see that the Harvey is severely dilated, at least bigger than the LV. So probably here, no Harvey failure. Here, Harvey failure. If you combine, as we discussed yesterday, with the CVP measurement, you will find an elevated CVP. And here, something in progress between normal Harvey and Harvey failure. And you remember, this is the study that I showed you yesterday, that indeed when you associate the evaluation of Harvey size using TEE with the CVP, you are able in patients with septic shock to detect in a significant number of cases that there is Harvey failure. Just to show you that this is not only pictures, this is not for publications and so on, but it has really an impact on the treatment that you apply. And this is something that we try to demonstrate here in this study in a small series of 46 ventilated patients with septic shocks, in whom we did a TE in the first 3 hours. And our goal finally was to compare the treatment that we applied using our TE approach, which is there, significant respiratory variation of the SVC fluid administration, no respiratory variation and normal LV systolic function, norepinephrine, and no SVC respiratory variation, but poor LV systolic function, inotropic support. And to compare that with the treatment that we would apply if we followed the surviving sepsis campaign based especially on the CVP, the mean arterial pressure, and the SCVO2. And I just let you a few minutes to look at the fluid administration, the norepinephrine, and the inotropic support was a little bit different in terms of definition. Look at, for instance, inotropic support required a CVP elevated. This is the first session of the surviving sepsis campaign, a normalization of the mean arterial pressure, and a SCVO2 below 70%. And look at the results that we found. If we just look at the need for fluids, the surviving sepsis campaign in 14 patients said, yes, you have to give more fluids, while the TEE said no. So it means that maybe if the TE is right, and I am really convinced that the TE is right, the surviving sepsis campaign led you to give useless fluids in 14 patients. If you look at the need for inotropic support, in 11 patients, the surviving sepsis campaign said no, while the TE said yes. And this is especially related by the fact that in this patient, the SCVO2 was in the normal range, which is something well known in these septic patients. Just I want to continue very quickly and just to show you this study. So 183 septic shock patients using the TE, and just imagine that you are able to to look at the relationship between the LV ejection fraction and the cardiac index. And maybe you are able to split these patients in different subgroups. One which is related to LV systolic dysfunction. The second one, probably even if the ejection fraction is low, the cardiac index is preserved. So there is some adaptation, so no inotropic drug is required. Here you have an hyperkinetic status with a high cardiac index. You could, so probably there is a persistent profound vasoplegia, and some authors propose to infuse the beta blockers in this patient. And finally, the last one here could be a normal LV systolic function with low cardiac output, which is still hypovolemic patient or IV failure. So I just want to conclude with one slide just to show you that you may have the same approach using this small TE probe which is single use, and that you may leave in place during 3 days in the patients, but we don't know exactly how to use it, in which patients, and I have to say that this is a little bit it is costly. So it could be interesting in the future, but we really don't know at this stage how to use it. And I really thank you for your attention, because my time is over.
Perfect. So we'll go ahead to Dr. Ashraf Tayyar, but you caught my question was about how many TOE probes you have in your unit to facilitate TOE SVC assessment for every patient. Just in 10 seconds, if you have plenty of them.
So we have two TE probes, but the key point is that we are able to clean the probe inside the unit. It means that in 20 minutes, the probe, we may reutilize the probe because we do it in the unit, but we have two TE probes.
Lovely. That explains it. So 20 minutes preparation is a very quick time.